I just want to also begin by sharing with you, and I apologize for the haziness of this slide, but I was recently participating in a think tank with Medscape and the Heart.org, some of our biggest online educators in medicine in general and cardiovascular medicine, on how we move forward with medical education and whether we consider meetings like this or other sources of information. And this is a figure involving a survey from well over 1,000 healthcare providers independent of cardiovascular medicine. The y-axis represents the impact or the influence that a particular intervention for education has on an individual provider's decision-making, his or her clinical decision-making. And the x-axis is the extent of reach of that intervention. And I simply want to highlight that the biggest impact for an individual's healthcare provider's clinical decision-making, one of them is in-person conferences. And the second, and the far right with the highest impact and the greatest reach, is not guidelines, is not high-impact medical journals. It's what the guy or gal next to you is doing in the cath lab or in the echo lab or in the imaging or in the clinic as well. And this Napa conference, I think, represents the perfect merger of both of those. We're in person, we're sharing, as Cybele just did, what we do on a daily basis, on a practical basis, Joe and Alan and others. And I think it's up to us and a responsibility to continue medical events like this and educational opportunities. Now, for chronic total occlusions and for two individuals, despite escalation of anti-ischemic therapy who remain symptomatic with isolated right coronary artery disease, the extent or severity of the anatomy heavily dictates the treatment and potentially the outcome. For example, for the individual in the left-hand panel, an interventionalist, at least reflexively, would go ahead and stent this right coronary artery with a large ischemic distribution. But for the patient on the right-hand panel with a chronic total occlusion, more likely this patient is going to be relegated to escalation of medical therapy if possible, or perhaps even a referral for isolated coronary artery bypass surgery. Now, the good news is a lot has improved in interventional cardiovascular medicine since Dr. Zimmerman published his report in 1955, in which preparation for cardiac catheterization required a cleansing enema the night before and prophylactic antibiotics. But there's a disconnect. There is still a disconnect in the interventional community where we're not fully treating the patient's need and meeting the patient's need based on what our skill sets are or what our risk tolerances are. And everyone in the United States wants to say that he or she is a complex interventionalist, but then again, probably shies away from certain clinical indications or lesion complexities. And in fact, to this point, this is very relevant in a country in which one half of all interventionalists perform fewer than 50 interventions a year. And only a third of the interventionalists in the United States perform greater than 100 procedures, which is still arguably a low number. So I want to share with you 3 patient cases for consideration in chronic total occlusion revascularization, 2 of which I'll share with you the outcomes, but one I still need your help with. And the first is a 53-year-old patient, all of these just coincidentally being under 65, a diabetic, hyperlipidemia, class 3 angina despite escalation of anti-ischemic therapies. And in March of 2022, this patient underwent attempted right coronary artery total occlusion. This is not my diagnostic angiogram, so I apologize for the extensive panning and movement, but you can appreciate a proximal right coronary artery occlusion, and left to right collateral is supplying a very large distribution of ischemia in the inferior and basilar territories. So this patient, the second patient I'll share with you is a 55-year-old male. He has a family history for premature coronary artery disease among multiple family members. Class 2 angina. As a postal worker, he walks his route despite escalation of anti-ischemic therapies. Now, he was not a surgical turn down. He turned down surgery himself. His father died of coronary artery bypass surgery, and his anatomy is quite more complex. So there's significant left main disease in the iliocaudal projection, significant ramus disease, and then a proximal left anterior descending artery total occlusion, supplying a large subtended territory with a large diagonal branch with left-to-left collateral filling. And then you see something else coming in too, is this large right coronary artery territory. And that's because the right coronary artery is also occluded proximally. And interestingly, the anatomy is such that these atrial collaterals then fill the LAD, and then distally in the apical segment, there's this tortuous, circuitous epicardial collateral that then supplies this large posterior descending artery and posterior lateral branch. So what do we do with these people? This is a patient I insisted he meet with one of our surgeons, and still he would not undergo bypass surgery. And then the third is a patient just of this week. This is a 35-year-old female, somewhat similar in presentation to Seibel's patient, who presented to one of our affiliate institutions in November with advanced heart failure and ejection fraction of 25%. She also had very severe mitral regurgitation, but has been put on a neprilysin inhibitor, SGLT2 inhibitor, among others, and now has moderate MR, is relatively clinically asymptomatic. She arrived in the clinic on Tuesday wearing a life vest, and her cardiac MRI shows an EF of 30% despite the advancement of a few months of good medical therapy and, interestingly, viability in all her territories. So what's the state of the state with CTO revascularization at present? Well, first of all, it remains uncommon, despite the recognition that for patients with identified coronary artery disease, a chronic total occlusion may be as commonplace as 1 in 5 patients. There still are persistent several misperceptions with regard to the clinical benefit of CTO revascularization, the relevance or irrelevance of collaterals, and uncertainties of procedural outcome and operator skill set. CTOs are the most common reason for referral to bypass surgery, and yet in clinical trials, the intention to treat does not work for revascularization of chronic total occlusions by CT surgery referral, because indeed about a third of CTOs are not bypassed due to the surgeon's discretion. And whether it's surgery or percutaneous revascularization, the presence of a chronic total occlusion is by far the most important predictor, the most potent predictor of incompleteness of revascularization. Now, the good news is that among experienced centers, procedural success rates with attempted CTO revascularization approach, if not exceed, 90%. And as I'll share with you, the in-hospital safety outcomes are not low, but they're also comparable to other high-risk complex anatomies and indications with PCI. And successful CTO PCI meaningfully reduces not only the likelihood for surgical revascularization, but it objectively, unequivocally reduces the ischemic burden compared with medical therapy alone. And it translates into very important improvements in patients' self-reported outcome and quality of life. But having said that, the advancement of CTO PCI to date has been largely handicapped by us as interventionists. It's been hindered by shortcomings in clinical trial design, in trial execution, and in part as a result of inconsistencies in the results and interpretation. One of the largest of these studies that really has set back CTO PCI was a study that was presented in 2017, but took over 2 years just to get into publication because of the limitations of the Decision CTO trial, which was a multi-center study performed in Korea, comparing, at least at first glance, CTO PCI versus medical therapy alone, and demonstrating parity with regard to a composite of clinical adverse events through 5 years of follow-up. The problem is that this is a misleading interpretation of the trial because, first of all, the trial changed its primary endpoint several times throughout the course of a 6-year conduct. It was prematurely terminated with less than 2/3 of the patient population intended for enrollment. Less than half of the patients were represented in the primary endpoint or the health status measures at follow-up. And what's very important is that 1 in 5 patients, although randomized to medical therapy, crossed over and got their CTOs treated. And conversely, 1 in 10 patients, 10% of the patients randomized to CTO PCI, never even had an attempted CTO as well. And moreover, the number of stents used in both groups was very similar, implying that perhaps the people in the medical group weren't treated just with medical therapy, but got a lot of other lesions that weren't CTOs that might have been ischemia causing, treated with PCI as well. And so it highlights the limitations of these studies because at first glance, by an intention to treat randomization assignment, there's a 1% absolute difference that favors medical therapy over CTO PCI. But as we drill down on this and look at an as-treated population, those who actually got the CTO treated and those who were treated with medical therapy alone, there's now an absolute 6% difference that favors percutaneous revascularization. One issue, however, one achievement with CTO PCI, like with PCI of non-CTO lesions, however, is an improvement in symptoms and quality of life for patients. In our prospective trial, which was a 500 consecutive survey of CTO patients reporting their own health status by the Seattle Angina Questionnaire, for the 60% of patients who experienced daily, monthly, or weekly angina with successful CTO PCI at 1-year follow-up, more than 80% of these patients described no symptoms whatsoever. This is discordant, though, or disparate from the results of the Decision CTO trial, the randomized study that demonstrated not only any improvement in clinical outcome, but no improvement in patients' health status. On the other hand, there's a large Euro-CTO randomized trial that did show an improvement with CTO-PCI in patients' symptoms, albeit to be fair, with escalation of medical therapy, there's an improvement as well, though to a lesser degree than with CTO-PCI. And then we have these larger registries, such as the multi-center open CTO US registry or the prospective registry that I just shared with you, that demonstrate even greater improvements, albeit not randomized, in patient-reported health status. And one of the differences, too, highlights the limitations of our CTO clinical trials, is that if we look at the baseline here of the baseline level of angina severity by the Seattle Angina Questionnaire, with 60s to 70s being daily or weekly angina, and 80s being maybe monthly angina or very limited angina, the randomized trials are enrolling patients that are less symptomatic than those in the registries because, again, there is a reluctance or a selection bias among the operators to put patients in randomized trials who are very symptomatic with the physician belief that perhaps they need to have their artery revascularized. Just to share with you, a lot of this is going to be resolved hopefully further in a large ongoing study which is taking some time to enroll in the CTO space in Northern Europe, randomizing up to 1,200 patients to medical therapy versus CTO-PCI, but designed to overcome many of the limitations of previous trials to avoid the selection biases that exist in previous trials and looking at potential improvements in both quality of life and clinical outcome as well. So really, when patients come to the clinic and they're thinking about CTO-PCI or they're referred for such, there are two principal questions for them. What's the risk of this procedure, and am I going to get benefit? And with regard to the risk, we can estimate for them that the risk of procedural or in-hospital mortality is certainly going to be less than 1%, and it's going to be comparable to other complex PCI indications. In fact, in the ACC-NCDR database, the risk of in-hospital mortality with saphenous vein graft PCI, which we think is relatively benign, is 1.5%. The risk of procedural myocardial infarction that could meaningfully injure the heart is also on the order of about 1.5 to 2.5%, and it's actually less by the same metrics, by the same definitions, than what we experienced in the Excel trial with left main PCI. Technical success rates, as I mentioned, in experienced centers now with experienced operators may breach 90%, and this is certainly an advancement over historical metrics such as ACC-NCDR, in which the success rate for CTO-PCI neared 60%, so just a little bit better than a flip of the coin. The second question, though, for patients is, is my outcome going to be improved with this procedure? And to be sure, for symptom improvement, I think this is less debated. Particularly, we have one large randomized trial, notwithstanding the Decision CTO trial, demonstrating a benefit with CTO-PCI. We have several observational registries also suggestive of this from patient self-reported metrics. But again, it's hard in situations of asymptomatic patients to make an asymptomatic patient feel better. So can we improve event-free survival? Well, this is suggested by large observational registries, but certainly there's no randomized data, and largely to the broader extent with PCI, that except for selected instances, that we improve survival itself. And the other big issue, however, that has been a mainstay for CTO-PCI is perhaps improving left ventricular function. Now, we have two randomized trials in the CTO space that have not shown improvements in LV function with successful CTO-PCI, but again, with limitations of clinical trials, these studies involved patients with relatively normal baseline LV function, so it's hard to improve upon an already normal baseline. But the revived BESIS trial recently published in the New England Journal of Medicine wasn't specific to CTOs, but recalled that an LV dysfunction, even in the presence or absence of viability, did not seem to demonstrate improvements in LV function with successful PCI. So very briefly, for our first patient who had a prior attempted right coronary artery CTO in March of 2020, he underwent at our institution a second attempt. Now, in this instance, we're ultimately able to successfully revascularize, or I should say achieve guidewire recanalization into the distal true lumen. But it's down, you see the guidewire into this posterior descending artery branch, and there's extensive dissection throughout the entire artery. So we've created a lot of trauma within the wall of the artery itself, and we've even compromised flow into the large posterior lateral segment that has a hematoma that's compressing the lumen. And so if we stent all the way down and place stents to the very end of the posterior descending artery branch, we're probably doing very little good for this patient. We're not achieving completeness of revascularization within the target territory. So we call this an investment procedure, and we allow the vessel to heal, and we intentionally bring the patient back in about 6 to 8 weeks. And when we do this 6 weeks later, you can appreciate that that whole distribution, that whole distal territory has now fully healed and recovered. And now there's actually just a small microchannel through the vessel that a workhorse guide wire can cross. So it turns a complex procedure into a very simple, straightforward one, and we achieve successful revascularization of this large territory. Our other gentleman was a little bit more complicated, the postal worker. Now recall, he would rather pass away than have bypass surgery. And so we offered him complex revascularization over a staged period of procedures. And the first was to treat this right coronary artery. And just after doing that, I just wanted to probe this epicardial collateral to see if we could do a retrograde procedure through it. And you can see the corkscrew, and I say that in the setting of Napa, this corkscrew appearance of the guide wire that, if anything, would straighten out that large epicardial collateral if you tried to cross through it, cause significant ischemia for the patient, and the patient wouldn't tolerate that. So we instead went through an antegrade approach, and I won't belabor the methodology of the procedure itself, but we're able to save all of the branches with a subintimal reentry technique. We treat the ramus, we treat the left main artery as well, and we achieve completeness of revascularization for this patient, who now continues to do well clinically as well and is asymptomatic. And the final one is my last one. This is the 35-year-old that I saw on Tuesday. So she's doing fairly well from a heart failure perspective, does not have angina symptoms, but she has no significant LAD disease, but a total occlusion of the proximal circumflex artery, and you can appreciate faint left-to-left collateral filling of the circumflex, a large RCA distribution with a proximal occlusion as well. And so I'm interested in hearing from you all, perhaps too, about what therapies. And she's on great medical therapy as well. Persistent LV dysfunction, though, again, comes in wearing a life vest and is motivated to do something because she's got a small young daughter as well. Would anybody, and again, has been seen by our surgeons, but at least for us, Joe, our folks perhaps think she's too high risk. So how many would offer her percutaneous revascularization, knowing that existing data that we have, by a show of hands? Thank you, guys. All right. And how?
35, you should be able to get, hopefully, an integrated approach.
Yeah.
So.
How many would not? How many would say continue what you're doing? That's okay too. But she was referred by both one of our heart failure cardiologists and one of our interventional cardiologists. And I said, look, based on your MRI, everything is viable, but I can't guarantee that there's going to be an improvement in LV function. We've had normalization in cases like this, but we've also got clinical data that would suggest otherwise. And she wants to go ahead with proceeding, so we're going to do that. So I'm just going to end. I'm going to end here with just a few thoughts from not an interventional cardiologist, but from my friend John Spurtis, who developed the Seattle Angina Questionnaire. And John mentioned this at one of our CTO summits, that this is really the state of CTO revascularization. Our trials have been limited by trial conduct and errors in design and selection biases. The contemporary studies do provide unequivocally strong improvements in quality of life and symptomatic benefit for patients with CTO PCI. But we need to explicitly sit down with these patients beforehand. This is not an ad hoc procedure where we don't take time with the patients and their families to explicitly describe the risks and benefit profile here in a shared decision-making process. And I think as we move forward, not simply with CTO trials, but like with Optimum, with other studies where we focus also on patient preference and patient self-reported outcomes, this will help advance the field for CTO PCI.